This call is now
Okay.
being recorded.
So we will study first the pathophysiology of this particular disorder, the underlying cause as well. And then we will also learn the mechanism of actions of antipsychotics. So this would be the topic outline for today's session. Okay, so kindly take note. We will begin with the pathophysiology. So that would include discussing the four major pathways of dopamine pharmacology, in which you are already somehow familiar because I have given this as an advanced activity, no? Yung apat na major dopamine pathways. Okay. And then we will also discuss the MOA, okay, general MOA, and then the list of antipsychotic. And then incorporated na dun yung clinical applications. And then lastly, very important no, to consider here is the adverse effects. Now, since we will be talking this time all about CNS drugs, so graduate na mo sa ANS, graduate na mo sa autonomic nervous system pharmacology, this time we will begin discussing the central nervous system drugs. So, since you will be encountering CNS drugs, you have to take note nga kaningang mga drugs, they are said to be non-polar. So kung non-polar, they have to penetrate, no? They can really penetrate, they can absorb to the triple B, the blood-brain barrier, okay, para ma-absorb sila sa central nervous system. Okay? So, given that idea, it is important na in the management of a patient case under psychiatric care, okay, kung ikaw as attending physician, we do not usually rely only to the efficacy of the drug, okay, against that particular CNS disorder. Okay. I repeat, we don't just consider no how effective the drug is in choosing, okay, a medicine for patient care, okay, kapag ang patient may psychiatric disorder or any mental disorder, CNS disorder. Okay, you also have to consider as well, most important, the adverse effects. Okay, knowing nga mo absorb na siya, mo penetrate na siya sa imong brain, bahalag effective pa na siya pa ang pinaka-effective nga drug, you have to consider its adverse effects. Okay, in relation to the patient case. Okay, so ang side effects of the drug must be considered. Okay, kasi again, the drug's active site this time, I mean the drug's site of action involves central tissues, not peripheral tissues. Now, in order to gain better understanding on the mechanism of action ng drugs, antipsychotics, it is important no, to discuss the role of dopamine in the development of psychosis. Okay? So, class, please tandaan na ang monoamine nga neurotransmitter, which is dopamine, this plays an essential role in the pathophysiology of psychotic disorders. Okay, so example ng psychotic disorder wherein yung dopamine really plays an important role is the schizophrenia. Okay, so based on the dopamine theories, mga hypotheses about dopamine in relation to psychosis, it is believed nga yung pagkakaroon ng unusual behavior or experiences associated with a person having psychosis may be largely explained by the changes ng function of dopamine in the brain. So mainly, dopamine gyud ang bida, okay, bida-bida kung naay psychosis, okay, nga disorder. So there is something nga changes sa activity ng dopamine, specifically dopamine receptor. Now, for talking about dopamine, dopamine, it has four major pathways by which it affects the brain. Okay, so na siya'y upat ka major pathways. So as illustrated, in this slide, there are 4 dopamine pathways that you should be familiar with. Okay, before mo mag-study about antipsychotics, you have to understand this 4 dopaminergic pathways. So first, we will discuss mesolimbic, followed by mesocortical, then the tubero, saan may pagbasa? Tubero-infundibular, no? Nga pathway, and the Nigros Triatal, okay, pathway. So let's start with the first one. We have here the mesolimbic, okay? Mesolimbic pathway. Now, the mesolimbic system or mesolimbic pathway, this is very, very essential, very important siya sa patient with schizophrenia. Okay, particularly ang mesolimbic pathway, this is thought to be hyperactive, okay, in schizophrenia cases. That's why may arrow up dyan. Okay? So, ang ibig sabihin niyan, in those patients with schizophrenia, there is increased activity in this pathway, sa mesolimbic pathway, mesolimbic system. So, what does it imply kapag increased ang activity in this pathway? Mind you, first, dapat inyo sang ibalan unsa dining naa sa mesolimbic system. Okay? So mesolimbic system, this contains the accumbens, okay, nucleus accumbens, the amygdala, hippocampus. Okay? Now, overactivity, hyperactivity of these parts in the brain due to the neurotransmitter nga dopamine, that causes patients with schizophrenia exhibit symptoms like hallucination, okay, delusions, disorganized speech or thought, and also bizarre behavior. Okay? So, bantog di ay, kung namoy kailang nga friend baka ha, or mutual friend nga diagnosed with schizophrenia, they usually exhibit these symptoms. Hallucination, familiar man ta ana, di ba? May tag hallucination, ang pinaka-common ani nga hallucination that is being observed to schizophrenic patient is yung auditory. Okay, auditory, dagan man klase hallucination, pwedeng visual, no, pwede olfactory. Kung auditory, kana bitang whenever a person hears something that a normal person do not hear. Okay, so nasiga kadunggan mga pakamatay na, ano bitaw. So ina hallucination. Okay? Delusion, ito yung paranoid. Okay, false belief. Okay, paranoid, paranoia. Okay, delusion. Disorganized speech or disorganized thought. So, sabotable naman sa iyahang term. Okay, kana bitang magstorya siya, disorganized bitaw ang iyahang concept nga gipangyaw-yaw. Okay? Kanang gabalintong ha? Di siya masabtan ba? Okay? Then bizarre behavior. Ito naman yung unusual or strange niya nga mga actions. Okay? Or yung attitude or behavior. Okay? Now, this group of symptoms, take note, this group of symptoms, these are termed as positive, okay, symptoms. When we say positive symptoms, these are symptoms that abnormally adds up, no? It adds up something to the normal behavior of a person. Di ba ni sila normal, di ba? Sa usa ka normal nga person, dili nato ni gakakita nga mga symptom. So mura siya ga-add up, okay? Nga ma-over na, ma-abnormal na ang behavior sa tao. So positive, yung mga gina-add up, okay? Which is making it abnormal. Okay. Now, if you come to think of it, no, kanis sila nga mga symptoms, these are very disturbing, very alarming, no, nga mental condition or mental symptoms. That is why ang patient, okay, ang patient, schizophrenic patient, or let's say naagyo siya severe, no, severe nga schizophrenia, he or she must be monitored. Okay? They must be given a proper treatment, proper management. Kay ang tendency, kung very severe bitaw iyahang schizophrenia nga level, kana nga person with that condition is more likely to commit suicide. Munang suicidal na usahay ang mga schizophrenic nga pasyente. Okay? So again, all these positive symptoms, these are caused by increased activity of mesolimbic pathway. So dapat sa inyong answer para perfect tong number 1 mesolimbic pathway, biska na lang kung makita nga positive symptoms, kana siya ang mesolimbic pathway siya ang related sa positive symptoms ng schizophrenia. Okay? Next. So done with the first pathway. Next, we also have the mesocortical pathway. Okay? Now, ang mesocortical pathway, unlike the mesolimbic system no earlier nga slide, ang mesocortical pathway, this is thought to be underactive naman. So kaganina, overactive, hyperactive, ang mesocortical pathway, underactive siya in schizophrenia. So kaninga part sa brain, kaninga pathway, which involves dopamine, no? Underactive naman siya in schizophrenia. Therefore, opposite siya with mesolimbic pathway. So kaninga pathway naman, it mediates the what we called negative symptoms. Okay? So aside sa positive symptoms nga itong ma-observe sa mga schizophrenic patient, napod sila'y observable nga negative symptoms. Usually, ang negative symptoms has something to do with the cognition, no? Cognition ng patient. Okay? That's why this is also termed as cognitive symptoms. Okay? Kung may cognitive cognition, that involves the conscious nga intellectual activity ng person. Kanang conscious nga intellect niya nga activity. Okay? Now, kung ang positive symptoms, it is termed as positive because it adds up something no sa normal behavior ng person. Kung may negative symptoms naman, it actually takes away or subtracts something from the behavior of a person. Okay, in particular, what we notice, what is being manifested to patient with negative symptoms includes loss of motivation, or this is also termed as avolition. Okay, loss of motivation na siya. Wala siya, kuan ba, kanang motivation drive. Okay? So, avolition. Flat affect. Ito naman, this is observed to a patient when he or she speaks a monotonous voice. Kabantay mo anang mga tao nga monotonous. Kung magstorya siya, monotonous lang gid iyahang voice. Kung may kag monotonous ang voice, mono, uniform ra bitaw tanan iyahang tune sa iyahang voice, dili ga change ba ang iyang tono, okay, sa iyahang voice whatever the situation is. Example, happy. Hala, happy ko. Naisunog, hala, sunog, gawas na ta. Kanay nga na bitaw, so flat affect, okay, monotonous voice. So somehow naakoy student actually. So bago lang siya ni graduate, he is diagnosed with mild lang noon, mild nga schizophrenia. But I will not disclose, of course, the name. Okay? So kung naamoy na ila, last kaning bago lang ni graduate, kaya wala ni paso, kay nag-COVID, apel siya dito sa ni graduate. So lalaki siya. Okay, so that is flat affect. Next is alogia. Alogia, this is poverty of speech. Okay, poverty of speech, diba? Poverty of speech, meaning ang patient do not talk, no? Do not talk much. Okay? Gatok gyapon siya pero dili gyud kanang gabi gyud kang sabaan gyud kanang murag si sala. Okay? Kanang sakto lang, no? They prefer to be silent. Joke ka to sala ha. Okay? Dala tinuod. Anyways, so that is alogia. Okay? Anhedonia naman, inability of a patient to feel pleasure. Okay? Kami itong example, example lang ni siya, example sa klase, na amang gid mo classmate nga kanang itong kingkoy, kanang sige siya joke. Then assuming nag-joke siya sa klase, legit gid nga katawanan gid iyahang joke. So everybody would laugh. Nabi nga na 'di ba sa klase kung mag-joke, everybody would laugh. But for a person with schizophrenia, it's not funny for him, okay, or for her at all. Okay? Ang worst, kung ga-decide ka, kung ikaw nga jukeron nga estudyante, okay, sa inyong klase, unya mag-throw ka og joke, ana mismo nga person nga na schizophrenia, better not to do that because that person will take your joke offensive. Okay? Para sa iya dili na katawanan. So, di ba? Mo na siya ang anhedonia. Okay? Inability to for a patient to feel enjoyment, fun. Nga bitaw. And then, social withdrawal naman, okay, that is also termed as asociality. Okay? Asociality. So, absence of socialization. A person has no desire at all, no, for social interaction. Mas kuan siya, mas ga-prefer siya og kanang alone, no? So, ganahan siya nga loner bitaw siya. So, that is for social withdrawal asociality. Okay? So, all these negative symptoms, these are primarily caused by decrease naman of dopamine activity in the mesocortical system. Okay? Now, when you talk about a positive, no? Kung ato siyang i-compare between positive and negative symptoms, naturally, no? Ang negative symptoms, they can be seen sa normal nga person. Di ba naa may tao nga introvert, no? Ganahan siya nga, kuan lang yun siya kanang alone. Naiusahay ganahan ta naatay quality time sa atong own, di ba? Naiusahay nga para sa ato dili man siya joke, no? Naiusahay nga di ta ganahan magstorya, maghilom lang. Okay? Alogia, di ba? So negative symptoms somehow this can be seen sa mga normal nga person. Okay? So, kung atong i-compare, no, positive and negative, ang much more delikado gyud, ang alarming gyud is the positive symptoms. Okay? Kasi yung negative one, aside sa makita siya sa normal nga person, dili man gyud siya kanang grabe ka significant gyud nga significantly observed ba sa normal person. Example, alogia. Dili siya ganahan magtok, dili man all the time gyud, naalay example 1 day 2 days, pero kanag yung long term na bitaw nga di siya ganahan iyan nag yung attitude nga di siya ganahan magtok. Okay, so mo na siya ang schizophrenia. But for a normal person, 1 day 2 days nga di ka ganahan magtok, normal pa ka ana, so ayaw mo kabala ka. Okay, so again, between positive and negative symptoms, very alarming yung positive one. So far, we have talked already two dopaminergic pathways, the mesolimbic and the mesocortical pathway. Okay? Now, I have always mentioned nga kani sila nga symptoms. Related din sila sa schizophrenia. That is why pag symptoms Always remember ha, sa schizophrenia, pwede positive symptoms ang ma-observed and okay, negative symptoms. Okay? But again, I repeat, positive symptoms ang much more nga ginahatagan og proper nga pharmacological treatment. Kasi with negative symptoms, pwede naman siya non-pharmacological ka na lang proper psychiatric counseling or tagaan siya recreational activities. Diba? It has something to do with his or her cognitive kuan man, intellectual activity. Okay? Now, to give you also an advanced idea, no, advanced lang ni idea, although ako ni siyang i-repeat later on, nga concept, when we talk about antipsychotics, kung nanay presence, no, of, or administration ng drug na antipsychotics, okay, mga antipsychotic medications, always be reminded, no, nga ang lahat as in all, no, all antipsychotics, ang ilang mainly nga ginatreat is the positive symptoms. Okay? How do they treat positive symptoms? Ano yung nangyayari sa positive symptoms? Kumusta yung level ng dopamine? Di ba sabi, taas yung level ng dopamine. Okay? Sa mesolimbic pathway. Kaya nagkakaroon ng positive symptoms. So, with antipsychotics via decreasing the dopamine level, okay, through blocking, no, i-block ang dopamine receptor, pwede ma-manage ang positive symptoms. Okay? Now, you have to analyze this ha, understand this, kay later on, basing magsagol inyuhang inyong learning sa upat ka dopaminergic pathway. Ang related lang sa symptoms, no, nga atong gakakita sa schizophrenic patient is katulang symptoms nga gina-regulate sa mesolimbic o mesocortical pathway. Katong another two nga dopaminergic pathway, it has nothing to do with the symptoms, no, or manifestation ng isang schizophrenic patient, but they are important nga inyuhang ma-learn because they are involved to the adverse effects naman ng antipsychotics. Okay? Para later on, di mo maglisod nga naman nga ang antipsychotics na ay ingani nga adverse effect. Okay? It is because naigo pod ang other nga dopaminergic pathway. Okay? Kaya dili lang man duha lang, di ba, ang dopaminergic pathway, upat man. Okay? So again ha, antipsychotics in general, because of the enhanced nga activity ng dopamine sa mesolimbic system, yung ginagawa ng antipsychotic, it will decrease, no, the dopamine level via blocking the dopamine receptor. So, pwede niya ma-manage ang positive symptoms. Okay? Now, let us proceed, no, to the third pathway. Okay? So sa third pathway, we have what we call the tuberoinfundibular pathway. Okay? So naturally, kani nga pathway also uses dopamine. Okay? So the same with the other pathways or systems. Ga-use up gihapon siya og dopamine. Once again ha, this is tuberoinfundibular pathway, humanata sa duha. Okay, first two. Now in particular, kani nga pathway naman, this controls the prolactin release. Okay? Again, this controls the prolactin release. Okay? Or it regulates. Okay? Regulates prolactin release. Unsa sa ang prolactin in order for you to understand the mechanism later on ng side effects ng antipsychotic. So, ang prolactin in general, they inhibit the hormone called gonadotropin releasing hormone. Okay? Gonadotropin. Okay, i-search lang ninyo iyang kuan iya. Pwede naman na siya mas na-search, no? One click away sa Google engine. Okay, gonadotropin releasing hormone. So from the term itself, isa siyang hormone nga ga-release sa gonadotropin. Tama, kay gonadotropin releasing hormone siya. Okay? Take note ha. Si prolactin gina-inhibit niya ni nga hormone, gonadotropin releasing hormone. So kaning gonadotropin So atong ginakuan ha, divide ang mga terms. Okay, from prolactin nga ga-inhibit siya sa hormone nga GnRH, akong i-define unsa dining gonadotropin. Gonadotropin, this hormone, this triggers the testicle ng lalaki to make testosterone. Okay? Then sa babae, it triggers naman the ovaries of the female to make estrogen and the other hormone, progesterone. Mo nang importance ni gonadotropin. But again, its release, okay, ng gonadotropin is being inhibited by prolactin via this pathway. Okay? Now, in the illustration, kakita kag babae, no? Then ang prolactin na ay arrow towards the breast of the female because prolactin, okay, in general, ang prolactin as a hormone, no, it contributes actually a lot, hundreds of physiological functions sa body. Pwedeng sa female or sa male, but this is very much significant iyang number sa females. Now, unsa man ang ginabuhat ni prolactin? Let's start first with the females. Kaya mo man ang nasa illustration. Prolactin sa females, these are involved for milk production. Okay, again, these are very much involved to milk production or sa development also ng mammary glands. Okay? Development of mammary glands among females. That is the importance ng prolactin. Again, importance ng prolactin in general. Okay? Based ani nga illustration. Okay? Sa males naman, kung mag-search mo sa function ng prolactin among males, it is not well known, no? It is not well studied. But usually, ang manggawas nga functions ng prolactin based on studies is that among males, this is much more involved. Dili lang sa males, no? Pati sa females, this is much more involved to sexual satisfaction. Okay, so that is the importance of prolactin. Okay, aside from that, it is also important for the immune system, both males and females also. Okay, so as you can see, wala gyud specific lang kay males. Kasi nga, again, much more pronounced ang number of prolactin sa females. Okay? Particularly, very important yun siya sa milk production mo gina ang first two nga responsibility ng prolactin. Okay? Now, I have mentioned in this pathway sa tuberoinfundibular pathway, di ba nga, it regulates. Sabi ko kanina, it regulates, it control the prolactin release. Okay? Now, that mechanism, okay, kani nga mechanism nga gina-regulate niya, kung yung kag-regulate, di ba, is decrease. Gina-control nimo, slow down nimo, marga na bitaw. So, gina-decrease ang prolactin release here. Now, kana nga mechanism, that is due to the action of dopamine. Okay? That is due to the action of dopamine in this system sa tuberoinfundibular pathway. Okay? So, take note, the role, the presence of dopamine in this pathway is to inhibit, to regulate prolactin release. So, please take note ha. Kapag may dopamine sa pathway na to, inhibited ang release ng prolactin. So, kung inhibited. Okay? So, inhibited lahat ng nasa baba. Kasi walang prolactin kung naay dopamine. Okay? Para dili mo makalimot, no? Just always keep in mind nga si dopamine sa brain, okay? This is also termed as PRIH. Okay? PRIH, ibig sabihin, it is a prolactin release inhibiting hormone. Okay? Prolactin release inhibiting. Gina-inhibit niya ang release ng prolactin. Okay? Kapag may dopamine again sa pathway na to, dumdumi, PRIH siya. Prolactin release inhibiting hormone. So, baba ang level ng prolactin. Okay? Therefore, kung atong hisgutan karon ang presence, kung naay patient, schizophrenic patient, nag-administered og antipsychotics. Okay? Again, how we're now talking about antipsychotic medication. Okay? In which I have told you earlier nga, mainly ang action ng antipsychotics, ano sabi ko, they block. Okay? Ang plus presence na ha, kung may presence of antipsychotics, okay? Ano yung ginagawa ng antipsychotics? It causes blockade minus block na siya. Block, inhibit. Dopamine receptor. Tama? Okay, I told you this earlier. Okay? Gina-inhibit niya ang dopamine receptor, di ba, to treat. Ang iyang gusto, it has nothing to do with the tuberoinfundibular pathway. Ang iyang gusto is i-inhibit ang dopamine receptor dito sa mesolimbic pathway. Kasi nandun yung regulation sa positive symptoms associated sa mga schizophrenic patient. However, with that mechanism, wala may giingon din nga dopamine receptor sa mesolimbic, pwede din mamili daw binapoy dopamine receptor na may dopamine receptor diri sa other nga pathway, other nga system, ma-block pud siya, no? Ang dopamine dira nga receptor. Again, with the presence of antipsychotics, okay, with their action nga they block the dopamine receptor, ang implication nito upon blocking dopamine sa tuberoinfundibular system, tell me what happens sa prolactin kapag na-block si dopamine with the use of antipsychotics. Is it high or low? Prolactin, very good. Increase ang prolactin. Wala may dopamine nga mo-inhibit sa prolactin release, so maintain ang release ni prolactin. That is why later on, Okay? Pag abot nato sa adverse effects, you have to inyo nang ma-understand, no? Ma-rationalize na ninyo nga naa usual side effect ang antipsychotic medication, which is hyperprolactinemia. Ate, prolactin na siya, denemia. Okay, so that is the reason. Okay, so supposedly ang igon is katulang positive symptoms. Syempre, no choice, maigo man yun ang other system. That's why associated, no, ang anticholinergic with this adverse effect or side effect, hyperprolactinemia. Taas yung prolactin. Question, kung taas yung prolactin, meron bang gonadotropin? Yes. Meron bang milk production? Yes. Meron bang development of mammary glands? Yes. Okay. So that is the importance of knowing the pathway tuberoinfundibular system. Okay, so later mas ma-emphasize pa ni nga mga side effects sa next few slides. Okay, so lastly, okay, last nga dopaminergic pathway is the Nigros Triatal pathway. So this pathway is more involved. Very important naman ito in the context of, dali na lang ako ibutang Parkinsonism. Okay. Kung naman mo sa second year, so sa mo nakadungog na mo Parkinsonism. No? Ang Parkinsonism, just to give you an idea, this is a degenerative disorder. Again, in general ang Parkinsonism is a neurodegenerative disorder in which ang pinaka manifestation yun or murag underlying theory bakit may Parkinsonism. Okay? It is because of the decrease in dopamine level in this pathway. Okay? So again ang Nigros Triatal pathway, this is very important, especially good sa Parkinson's disease. But again, we're talking about this pathway in relation man to antipsychotics. So, ako lang siyang gi-mention kay later on na ako'y ma-mention nga symptoms, okay, para ma-relate ninyo, ma-understand ninyo nga nung na ay Parkinsonism kung mag-take og antipsychotics gihapon. Okay? So, let's focus sa pathway na to in relation to antipsychotics. Now, ang main function ng pathway na to is, as written, it influence voluntary movement of muscles. Voluntary, take note It influences, okay, voluntary movement of body muscles. Okay? So more involved siya sa motor movement or motor coordination of the body. And take note, dopamine ulit, it is very important for this pathway. Kailangan yung dopamine for this pathway to stimulate that voluntary movement, that purposeful, no? Kanang ikaw gyud, no, nag-decide nga okay, maglihok ka ingani, okay? Imo ning ilihok nga kamot, so ingana bitaw. So kailangan ng dopamine an diri nga system, okay? Nigros Triatal system. Now, let's try to analyze what if na ay antipsychotic. Okay? So nakuha ninyo ang transition. Katong first two nga pathway relation sa symptoms ng schizophrenia. Kaning last two nga dopaminergic pathway in relation naman sa adverse effect ng antipsychotics. Okay? So kapag may presence of antipsychotics nag-administer sakto man ang spelling, no? Nag-administer ng antipsychotic, what if, no? So in general, again, there is blockade of dopamine receptor. So ana diretso basta na antipsychotic, ilag yung ginablock ang dopamine. Kay ilang gusto i-manage ang positive symptoms. Unsa day ang nahitabo sa positive symptoms, taas ang dopamine. So naghimo ang mga scientist og antipsychotic for the purpose of blocking yung dopamine receptor. So obviously, okay, with regards to Nigros Triatal system, kaninga system, okay, it would greatly affect the stimulation, the activation of voluntary motor movements kung naay antipsychotics, 'di ba? Kasi with antipsychotics, administration of antipsychotics, they would not activate the voluntary, unsay opposite sa voluntary. Okay? There would be involuntary, no? Involuntary nga mga motor movements. Kay gi-block man niya. So the opposite one. Okay? Again ha, kung dopamine in this system, it influences the voluntary movements of the motor movements of the muscles. Kung i-block, okay, ang dopamine with the presence of antipsychotics, that could induce, antipsychotics could induce involuntary nga muscle movements. Okay? Uncontrollable ba nga muscle movements. Mukalit rag contract, mangurog kag kalit, ga-contract imuhang muscles. Okay? Now, kani nga mga symptoms, okay, these are actually related to blockade of dopamine receptor in the Nigros Triatal system. Okay, and again, this is caused by the presence of antipsychotics. Now, this list of symptoms are termed as EPS. EPS, this is known as extrapyramidal EP symptoms. Okay? Again, ang EPS symptoms, not symptoms, redundant na, EPS or extrapyramidal symptoms, it includes acute dystonia, akathisia, pseudo-Parkinsonism, pseudo meaning Parkinson's-like symptoms. Dili gid katong tinuod nga Parkinson's nga disorder, false nga Parkinsonism. Parkinson's-like symptoms ayang pasabot ana. Tardive Dyskinesia, neuroleptic malignant syndrome. So all this, again, all this are EPS symptoms. Okay? And they all manifests involuntary. Kani sila, they all manifests involuntary, no? Motor movements. Okay? And again, that is due to the blockade of dopamine receptor in the Nigros Triatal pathway. Kani each of these EPS, it will be discussed in the kanang proceeding slides. Okay, so we will learn that later. What are the clinical features unta kita sa pasyente nga na dystonia and etc. Kanatanan. Okay? And then the development also ng each symptoms kapag nag-take ka og antipsychotics kanusa usually ma-observe ang dystonia. Okay? Example, karon ka nga din nagsugod og antipsychotics kanusa nimo ma-expected ang akathisia. Kasi these are EPS, ma-associate din ni siya sa patient with taking antipsychotics. Okay? Now, for now, just know that yung EPS, they are symptoms associated upon decrease, no? Upon decrease of dopamine, upon inhibition of dopamine release in the Nigros Triatal pathway. So kapag na-block ang dopamine in that pathway, EPS dayon. Kasi nga, from voluntary, na-block ang dopamine, involuntary na nga mga motor movement. So I hope na kuanhan nakuha. Another thing also, somehow you can now rationalize, no, based sa MOA ng antipsychotics, no? Based sa MOA ng antipsychotics, imong ma-rationalize why this group of drugs, kaning antipsychotics, they are said to cause symptoms like Parkinson's disease. Okay? I am referring to the pseudo, ha? Okay, pseudo. Ngano kaha kung mag-take og antipsychotics, may pseudo Parkinsonism, Parkinson's-like nga symptoms. Okay, so I know, klaro na sa tanan, ma-rationalize na. Okay, magkaiba ha ang Parkinsonism sa pseudo Parkinsonism. Although yes, both involves decrease in dopamine level, tama? Both, di ba? Pseudo, mapa-pseudo, Parkinsonism, both involves decrease in dopamine's action, no? Dopamine's action sa pathway na to. Di ba? Parkinsonism nga tinuod yun, nga Parkinsonism, sa Nigros Triatal, manggihapon na. Same with pseudo-Parkinsonism. So same sila pagbaba ng dopamine's action in this pathway. However, as sila nag-differ, they differ on the underlying cause why there is decrease in dopamine level in this pathway. Tama? Kasi sa Parkinson's, kaning totoo, no, kaning tinuod, kaning tinuod nga naday binuang false lang. Okay? So ang Parkinson's nga, kaning tinuod nga Parkinson's disorder, di ba sabi ko, this is a neurodegenerative condition. Kung may kag neurodegenerative condition, meaning to say, na ay natural nga degeneration, declinement sa neurons action in the CNS. Okay? So particularly for Parkinson's, katungan neuron nga nag-decline ang action is the dopamine. So natural nga nahitabo nga nag-decline ang iyahang action. Walay involvement sa drugs. Okay? That is Parkinson's. Neurodegenerative. Natural nga na degeneration, declinement sa neurons action sa brain. No involvement of drugs. Whereas, kung may yung kag pseudo Parkinsonism, okay, this is drug-induced. Basta makadungog kag pseudo Parkinsonism, ang gakos ana sa pag-lower, no, sa level ng dopamine in this system, it is because of a drug. Okay, particularly sa atong discussion, ang drug, okay, that causes pseudo-Parkinsonism, which is an EPS, is antipsychotics. That causes decrease in dopamine level in Nigros Triatal Pathway. Okay, so as a result, nibaba man ang level ng dopamine sa the same pathway, the same lang gihapon nga clinical feature ang ma-observe, no, sa pasyente taking antipsychotics with that of a pasyente nga naay tinuod nga Parkinsonism. That is why it is termed as Parkinson's-like symptoms. Okay? Kay naagi similarity, nag-differ lang yun sa cause nganong bumaba yung dopamine level on the same pathway. Okay? So later, you will learn as well what are the clinical features, okay, observed to a patient with Parkinsonism. Okay? Dito man nato mabase nganong gitawag siya Parkinson's-like. So example, kung ang patient man gyud na ay Parkinson's, okay, naa siya ga-tremors, okay, na ay rigidity sa iyang lihok, okay, etc. The same clinical features ang makita kung pseudo-Parkinsonism, kaya nga Parkinson's-like symptoms. Okay? But again, this is a pseudo, a false one, kasi drug-induced siya. Okay, drug-induced. Okay? Sige. So overall, we are done with the four major dopamine pathways that are relevant to the mechanism of action ng antipsychotics related to adverse effects ng antipsychotics. Okay? So, short recap, ang first two, again, mesolimbic, mesocortical, they are much involved to the positive and negative symptoms, respectively, no, sa patients in schizophrenia. The tuberoinfundibular pathway and the Nigros Triatal pathway, sila naman yung related, relevant, no, sa adverse effects ng antipsychotics. For tuberoinfundibular, it's hyperprolactinemia kapag antipsychotics affecting the Nigros Triatal pathway, there is what group of symptoms? EPS. Okay, so at this juncture, let us talk about antipsychotics MOA. So the general MOA, so na-mention naman ganina, no? General MOA, kapag may dopamine, no, may dopamine sa body, na siya'y daghan man nga mga receptors nga pwede i-bind. Okay? So, when we talk about antipsychotics, di ba, ang atong gusto is, kani nga antipsychotics, they could penetrate the CNS. And the mostly pronounced nga mga receptors, dopamine receptors sa CNS is dopamine 2, 1, and 4. But, ang pinaka-related yun sa psychosis, okay, is dopamine 2 receptor. That is why antipsychotics, ilang general MOA, is mainly to target, no, dopamine 2, okay, receptor. Dopamine 2 receptor. Again, because this is much more pronounced sa katong apat, no, nga pathways. Siya ang mas daghan ba nga type of dopamine receptor. Kaya mas siya ang gina-target sa antipsychotic. So, in general, take note, antipsychotics are dopamine 2 receptor blockers. This is the general one. Okay, general mechanism of action. Okay? Kung general, whatever the class of antipsychotics, naagad sila ability to block dopamine 2 receptor. Okay? Kuan lang ha, kaning addition, no? In addition, please take note nga, ang antipsychotics, these are also termed as neuroleptics. Kay basing malipat ko ba sa exam, magamit ko og neuroleptics nga term. Nya wala na ko siya na-introduce. So, kung maka-encounter mo og neuroleptics nga mga class of drugs, we are also referring to antipsychotics or kanang mga major tranquilizer, nakadong na mag-major tranquilizer sa mga series. No, tranquilizers, that is also antipsychotics. Okay, so the same lang na sila nga terms. Antipsychotics, neuroleptics, major tranquilizers. They are just on the same class category. Okay, so again, kaning a group of agent, they are primarily used to manage psychosis. Okay, and the very principal, no, principal or most common nga psychosis, okay, psychotic disorder being treated by antipsychotics is schizophrenia. Okay, schizophrenia. Okay? And pag may schizophrenia, ang most alarming nga symptoms nga gaka-observe sa ilaha are hallucinations, delusions, paranoia, and other nga mga symptoms nga more on positive symptoms. Okay? So that is why general MOA, they block, okay, dopamine 2 receptors, because dopamine 2, in particular, this is most pronounced in the mesolimbic pathway. Okay? Kaya, di ba, overactivity, kapag may dopamine sa mesolimbic pathway na ay hyperactivity, nagkakaroon ng hallucination, delusion, positive symptom. So, yung gagawin ng antipsychotic, target, okay, target nila ang dopamine 2, ma-manage ang positive symptoms. Okay? Sige. So let's have the classification, no, of antipsychotics. Okay, na-mention naman ako ang dopamine. Before pa. Okay, before ang list, no, before niya siya, ang list of antipsychotics, I will also discuss the other theory, hypothesis in some studies nga also contributes to schizophrenia. Okay? Aside sa role of dopamine in the pathophysiology ng schizophrenia, na ay mga present, no? Present lang nga mga clinical studies that have they have observed sa ilang results, sa ilang study nga usapod sa underlying cause nganong na schizophrenia is because of the serotonin. Okay? Serotonin. Okay? So, na yung mga present theories regarding the function of serotonin in the brain. Kasi in the brain, okay, they may somehow cause schizophrenic symptoms. In particular, na ay mga present studies nga they have observed nga na ay mga activator of serotonin receptor that could induce hallucinations, okay? Na ay serotonin receptor activator nga ga-induce og delusions, okay? Etc. But pinaka pronounced good is hallucination. Okay? Particularly, good example is LSD. Kadung na LSD. Okay? Lysergic. Kalimot ko, i-search na lang ninyo. Basta usa siya ka serotonin agonist. Okay? So somehow, iyang na pa increase, diba? Serotonin agonist, so enhance ang activity, no, ng serotonin. So, search na lang ninyo, LSD. Another is mescaline. Naka-encounter na mo anis sa PCOG, mescaline. Murag plant-derived na siya, mescaline. Okay, these are serotonin agonist. Okay, and present studies have observed nga this could cause hallucination. And recall, di ba, hallucination is a positive symptom in schizophrenic patient. That is why na ay mga theories, hypothesis nga via blocking serotonin daw din, okay, this would also, okay, somehow decrease, no, the dopamine level in the limbic region particularly. Okay? Again, I repeat ha, naay mga studies, okay, nga nag-theorize, nag-hypothesize nga via blocking, okay, via blocking serotonin, sige ito nga, serotonin 2A, okay, 2A, okay, 2A nga receptor, kung i-block daw po ang 2A nga receptor, this could, okay, in the brain this could decrease dopamine level, okay, in the limbic region, so mesolimbic pathway. And that has something to do with hallucination, diba? Okay. This is actually the action of LSD and mescaline. Serotonin 2A receptor agonist sila. Okay? That's why may hallucination. So via inhibition of that receptor, inhibition, no, of that serotonin 2A receptor which causes hallucination. Okay? Iyahang gina manage ang positive symptoms nga hallucination, okay, via decreasing dopamine level in the limbic system. So later on, naatay ma-encounter nga mga antipsychotic drugs nga naay miscellaneous additional ba nga effect aside from blocking dopamine receptor. Okay? Napod sila ability to block serotonin. Okay? So, win-win situation, giblock niya ang dopamine 2, napod siya ability to block serotonin, pwede siya as antipsychotics. Kasi, ultimately, ginapababa man niya ang dopamine level, ginamanage niya ang positive symptoms, okay, associated in schizophrenia. Okay, so in general, ang antipsychotics, they are classified based on generations. Okay, natay first gen, and we also have the second generation. Okay, we have first gen, second gen. Okay, ang first generation antipsychotics, they are also known as typical antipsychotics. Okay, so first gen, so sila ang first group of antipsychotics that came out being marketed commercially. The other class are the second generation antipsychotics. Okay? Sila naman, they are termed as atypical antipsychotics. By the way, when you encountered categories of drugs, bitaw any categories of drugs nga naay classification based on generation, example, ang kani antipsychotics na ay first gen, na ay second gen. Kung maka-encounter kaging ani, example ha, kani, or katong napatoy isa na discuss na ko nga class of drugs nga na ay first gen o second gen, the antihistamines, di ba? Yung H1 blocker na ay first gen, na ay second gen. Tama? Now, katong mga drugs, okay, under sa last nga generation or recent nga generation, they are considered the new, di ba, they are considered as the newer drugs. Ang rationale ana, nganong mag-produce og newer drugs? Ngano day mag-produce og newer drugs? Of course, para kapag-make sila og better nga drug than the earlier made nga drug. Okay? So, ang ilahag yung goal, ana, kung mag-produce, kung chemist manggani ka, imong panghuna-huna dapat, kung maghimo manggani ka og drug nga, the same classification, example, gusto ka maghimo og antibiotic, okay? Nga pang 6th generation na cephalosporin lugar. Okay? Naman, marag 5th naman ang cephalosporin. No? Gusto kag 6th generation nga group of drugs. Ang imuhang goal gyud dapat is mag-produce ka, maghimo ka nga equally effective to the older nga group of agents but lesser side effects, or more effective than the older or earlier generation and lesser side effects. Okay, so nga na dapat ang kuan mo ni siyang na ay first gen, second gen, because napagtanto ng mga chemists ang first gen, uy, daghan kaayo sila adverse effects. So we have to create another set of the same class of drugs nga either equally effective or more effective but with lesser side effects. Muna inyong ma-observe nga ang mga recent, ang mga last nga generation, mas lesser ilahang side effects compare sa katong pinaka-prototype, pinaka-una. Okay? So, nga na ang rationale nga nung na first gen, na second gen. Based na siya sa kanus agi himo. Okay? So, obviously, ang pinaka-last nga gen, siya ang recent. And siya ang lesser nga adverse effect. Pero dili ka pwede mo ingon nga siya ang much more effective. Okay? Depende gihapon na. Pwede equally effective. Pwede pod more effective siya than the earlier generations. Okay? The same goes with antihistamine, di ba? If you still recall, antihistamine, H1 blocker, first gen, they have significant adverse effects. Very pronounced ang sedation nga adverse effect. But with second generation, they are either less sedating or non-sedating. Kasi ang most common na side effect, di ba, sa H1 blocker is sedation. Okay? So, kana makatulog, drowsiness. Okay? So, that's the reason. Okay? Now, with antipsychotics, ang atong generalization again ha, with antipsychotics, you have to expect that first generation, they have greater adverse effects. While the second generation, they have lesser side effects. Dili ka mo ingon nga wala, nagyapon na lesser. Same naman di ba ang ilang gi-target nga site, gi-target nga receptor. Di ka pwede mo ingon nga wala gyud side effect, but somehow lesser side effect. Okay? So under first generation or typical antipsychotics, okay, these are the list of drugs and they are further classified based on chemistry. Okay? So based on chemistry, based on chemical structure or medicinal chemistry. Okay? So we have phenothiazines, butyrophenones, thioxanthines. Okay? Phenothiazines, they are further classified based on the side chain nga makita sa ilang structure. Kung ilahang side chain, example, nakakita kag phenothiazine, ang ilang side chain aliphatic. Okay? These are examples of drugs. We have chlorpromazine, triflopromazine, promazine, okay? Basta ending in promazine, ana. Ending in promazine, these are aliphatic phenothiazines. Next, we have piperidines side chain. Okay? Katong antipsychotics nga ilahang structure, chemical structure na ay piperidine side chain sa a mother chain phenothiazine. Okay? So we have thioridazine, mesoridazine, and so on. So ang inyong timailhan ini is dazine. Namang yung letter D. Ang piperidine. Dazine, then kamo na din bala mag-memorize sa ani. Okay? So nagiusahay nga di madalag mnemonics, no? Dazine, pang pinaka always nga makita sa choices is sa thioridazine under piperidine. Then we also have piperazine, no? Piperazine na ay piperazine side chain. Sa phenothiazine antipsychotics, we have trifloperazine, flofenazine, gidang tambal, no? Azine. Okay? So good thing sa inyong nga mga online student, you don't need to memorize this. But I would really suggest nga you start memorizing the drugs. Kay kamo ra man gihapon mabulahan, inig mag-board exam mo. Kay di biya mo maka-Google. Kay wala na mo friend ana kung mag-Google friend kung mag-exam na mo. Okay? But wa ko'y problema kung sa akong class, finals exam, hala sige pag open notes mo, di man gyud nako na makontrol. Pero again, ang akong suggestion is really for you to memorize. Familiarize. Or unsa pay tawag ana nga basta inyong madumduman. Okay? Piperazine, azine. Azine nga na akong pagdumdum, azine, piperazine na siya. So kani gyud imo gid memorize kay azine man gihapon iyang ending. Okay, so ikaw na bahala kung saan na nimo pag-memorize. Butyrophenones, ending in diba, ridol, so dali lang. Ito yung mga butyrophenones, antipsychotics. First gen ni siya first generation, di ba? Daghan kaayo, first gen pa lang gani. Okay, daghan kaayo ang na-make na drugs first generation. Then thioxanthines, madali lang, di ba, na ay TH sa iyahang general nga classification. So, makita raman silang name, fix. Okay? Sana lang. Okay? So, those are the typical antipsychotics first generation. Okay? So, let's have the mechanism of action ng first generation. Yung sabi ko kanina, yung general, mapaunsa ng antipsychotics, always na sila ability to block dopamine 2 receptor. Okay? Again ha, for first generation, take note, they block dopamine 2 receptor. Excuse me. Kasi nga, dopamine 2, nganong dopamine 2, this is most significantly distributed, okay, nga receptor sa brain. Dopamine 2 ang daghan. Okay? Now, these drugs, aside from dopamine 2 receptor blockade, they also exhibit miscellaneous miscellaneous nga activity or action. Miscellaneous action. Kung may miscellaneous action, additional. Aside sa ilang main, di ba ako siyang gibold, okay, bold nga font, naa siya mga somehow additional nga effect. Okay, and this is being exhibited by all first generation antipsychotics, and that is blocking histamine alpha and muscarinic receptor. So para din yung dali mahinumduman, this is anti-HAM. No, anti-HAM, na sila anti-HAM activity. Anti-HAM, antihistamine, anti-alpha, anti-muscarinic. Kung makadungog kang muscarinic, cholinergic na siya nga receptor. Okay? So dumdumi dayon. Kung ma-block ang cholinergic, so di ba anti-cholinergic siya, dumdumi unsa tong mga adverse effect ng isang anti-cholinergic receptor para later on inyong ma-realize, ma-rationalize, no? Nganong may anticholinergic side effect ang mga first gen. At that is because ginablock nila ang muscarinic receptor. Di ba? Between muscarinic and nicotinic, mas kung may kag anticholinergic effect, it is because of blocking muscarinic receptor. So anti-HAM ha, miscellaneous action, anti-HAM activity. Okay. Now, you have to take note this, no? Kung moingon tag dopamine blockade, okay, kanang iyahang ability to block dopamine and iyahang ability to block HAM receptors ng mga first gen antipsychotics, it vary. Okay, it vary depending on the potency of a drug. So dili sila equal og activity in blocking certain receptor. Ang ilahang level of blocking activity magbase sa ilahang potency. Okay? I repeat ha. All first generation antipsychotics, all, they do block dopamine 2 receptor. They have additional effect anti-HAM activity, but they differ on the extent, on the level of blocking activity of that certain receptor. And ang key factor to determine the extent of blocking activity towards that receptor is excuse me, potency. Okay? Now, take note ha, potency is different. Sige, color blue, no? Different siya from efficacy. Okay? Different siya from efficacy. When we say efficacy, unsa ganitong efficacy, nakalimot na mi ma'am. Okay, first prelim pa man to. Efficacy, it has something to do with the how effective the drug is. So, ang iyang measurement is the response, di ba? Ana ang mnemonics, basta it has something to do with the effect, with the response. It is the maximal. Okay? It is a measure siya of the maximal response of a drug. Katong yung pinaka peak niya nga response of that drug. However, kung may kag potency, we are not referring to response here. We are referring here to the dose. The dose that is required to achieve 50% no, of the maximal response. Okay? And based on your knowledge on potency, unsa ganito atong consideration nga ma-consider na siya as most potent, di ba? It is considered that the ano sa ba? The lower the dose, tama? The lower the dose or the lower the concentration of a drug, the greater, okay, iyahang ability to attain 50% of the maximal effect. Okay? So more potent yung drug. The greater its potency. Kung siya yung may pinaka lower dose, then na-attain na niya ba ang 50% na maximal response. So that drug is considered most potent. Now, going back to antipsychotics. Okay, tandaan, based on the potency of the drug, basa ha, it is directly proportional with the activity or affinity niya towards dopamine 2 receptors. Again, yung potency of a drug, it is directly proportional with its dopamine 2 receptor affinity, meaning to say, for first generation antipsychotics, the most potent the drug is, the greater is its dopamine 2 receptor blocking activity. Muna yung pasabot. Kung most potent ang drug, very potent ang drug, directly proportional, siya pod ang naay higher blocking activity towards dopamine 2 receptor. Okay? On the other hand, ang potency of a drug naman is inversely proportional with its anti-HAM, no? With its anti-HAM activity. Again, ang potency ng drug inversely proportional with the anti-HAM activity of the antipsychotics. Okay, so unsay pasabot. Let's say you have a most potent ang usa ka antipsychotic. Okay? So the most potent the drug is, opposite, inversely proportional, the lesser its anti-HAM. Okay? Being observed. Okay? Anti-HAM activity that is being observed. Anti-HAM ha, histamine, alpha, muscarinic. Okay? So let's try to analyze. Ngano kaha? No kani masabtan naman ni siya. Okay? So ngano kaha kung most potent ang drug, lesser lang iyahang anti-HAM activity. Again, balik ta sa definition nato sa potency. Kung moing kag potency, di ba, it is all about the dose of the drug. Okay? Now, when a drug is considered most potent, okay, kung ang drug is considered most potent, it only implies that only lower dose of a drug is needed to attain the desired effect. Okay. Now, what did I told you about the MOA of antipsychotics? MOA, the main MOA ng antipsychotics. Diba they mainly block dopamine 2 receptor. Therefore, with just low dose of the drug being administered, kasi nga most potent man ang drug, okay, with just a low dose of that drug being administered, it is only expected that the drug will be concentrated to the target site nga dopamine 2 receptor. Kay gamay raman ang dose nga imong gi-administered nga antipsychotic, knowing nga it is most potent. Kung may man gid kag potent ang drug, pagtan-aw nimo sa dosage niya, gamay ra gid kay na iyang milligrams. Okay? Gamay ra iyang value ba in milligrams. Knowing nga low dose na siya, and ang main site of action ng antipsychotics is sa dopamine 2 receptor, low dose will be concentrated only to the dopamine 2 receptor. Wala na mo abot sa histamine, sa alpha, sa muscarinic. That's why lesser anti-HAM activity with most potent drug. Okay? So, muna yung pasabot. So, that's why lesser here again ang HAM effects. Okay? With high potent na mga first-gen antipsychotics. So, kung vice versa, baliktaran, ato ibaliktad. Okay? Kung baliktaran, kapag low potency, okay? Low potent ang drug, okay? Low potency ang drug, syempre dili lang kung low potent, it is being prepared in higher doses, higher dosage. Muna siya, yun yung timailhan. Basta inom mo og mga tambal, lang tawa yung dosage. Okay, kung dako kayo yung milligram na, milligram, like 1,000 iyang milligram, 1,000 milligram, ana. Gidak-an ang iyahang dosage kay somehow least potent ang drug. Okay? So again kung low potent ang drug, it would have lower affinity to dopamine receptor. Tama? Kung ato ni siyang kaniuna ato ang i-analyze kung low potent, baliktaran man. Kung low potent, so directly proportional, low iyang dopamine 2 receptor blocking activity. Okay? So directly proportional. However, because we're talking about low potent drug, kailangan nato og higher dose. Okay? Kailangan nato og higher dose. Lahi ang potent sa dose kadaghanon na siya ang dose, concentration na siya. Okay, kailangan nato mag-require ka og higher dose of that drug to somehow attain the desired efficacy. Okay? So kailangan nimo dakuan ang dose. Okay? So dinaghan. So with that higher dose, pag administered nimo higher dose, higher concentration, that would really cause additional nga mga effects, mga miscellaneous action. Okay? It will have additional blocking effects towards HAM, receptors. Okay? So na siya greater anti-HAM activity. So I hope nakuha ninyo. With low potent drug, ang preparation na nila naka-higher, greater ang dose. With greater dose, aside sa ilang main target, syempre makonsentrate man gid una sa dopamine 2. No higher dose man naagi mapadulong sa other nga mga receptors. Okay, that's why naa siya associated nga anti-HAM activity. So I hope nasabtan niyo siya mag-base ang iyahang blocking activity sa dopamine, sa HAM receptors based sa potency ng drug. Okay? Kung more potent ang drug, lesser anti-HAM activity. Low potent nga drug, greater anti-HAM activity. Okay? Now, ma'am, how do we determine nga kana nga drug potent? Kani nga drug less potent? Okay? For first generation na ni siya first generation antipsychotics kani sila. Okay? So, muna sila ay, wala ko yung next slide. Okay, so based on potency, take note na lang dere. Dere na lang na ako isulat. Okay? So, para mabalaan ninyo, okay, kinsa man ani ang high potency. Okay? Most potent, equal ang potency, etc. Wala, time na. Okay, wait sa. So, please take note, butyrophenones. Okay? This is equally iyahang potency with piperazines. Okay? Piperazines. Greater ilahang potency with,
Ma'am, excuse me,
I
ma'am.
think na,
Nakabili na siya, ma'am.
di ay? Wait,
Oo.
sabi.
Nasa
Asa
last na
man?
bullet, ma'am. Sa pick, ay, back pa, ma'am. Patay mo
Asa?
ko nagsulatan, ma'am.
Asa? Ay, nara.
Subot atong inversely directly, ma'am.
Okay, nara gid ay. Sa tungod daghan na kay ang gisuot, wala na ako nakita. So nara. Okay, very good. Kay gatan-aw gid mo sa slide. So sorry for that. So mo ni siya. Thank you for that, Sala. So butyrophenones is equally potent with piperazines. So I hope nasabtan ni equal ilang potency. Silang duha greater ilang potency with piperidine. So tanawa na lang ang list of drugs ha para inyo ding ma-analyze. Then thioxanthines naman, piperidines greater or equal to iyang potency compared to thioxanthin. Then thioxanthin siya yung greater somehow iyahang more iyang potency with the aliphatic antipsychotic. So kung pangutanon mo, which of the following are most potent antipsychotic except, so pangitaa dayon si aliphatic, kinsay na belong sa aliphatic. Aliphatic chlorpromazine, katong mga promazines. Okay? Butyrophenone katong haloperidol.
Now being recorded.
Let us proceed to the second generation antipsychotics, or these are termed as atypical antipsychotics. As mentioned earlier, these agents are the newer agents. In particular, this group of agents are made available in the market with the same efficacy to that of the first generation antipsychotics. But the good thing about second generation is that they have lesser adverse effects. Meaning to say, they are less likely to cause EPS, the extrapyramidal syndrome or symptoms, or any other adverse effects in relation to dopamine blockade, in relation to anti-HAM effects. Okay? So these are the following antipsychotics that belongs to the second generation or atypical drugs. We have clozapine, olanzapine, loxapine, risperidone, paliperidone, quetiapine, ziprasidone, aripiprazole, molindone, and amisulpride. For the mechanism of action of the second generation antipsychotics, they still able to block dopamine 2 receptor. Again, that is the general MOA of the antipsychotics. Additional effects of second gen is that they are also capable to bind and block dopamine 4 receptors. And at the same time, they are able to block serotonin 2 receptors. Again, all these receptors are located in the systems that are relevant to the dopamine pharmacology. With serotonin receptors, recall, as mentioned in the prior slides, the blockade of serotonin 2A will result to decrease of dopamine levels in the limbic system. So somehow with this effect, it is able to offer clinical benefit towards managing the positive symptoms in schizophrenia. So again, with second generation, same efficacy with first generation, but good thing is that they were made with lesser adverse effects or lesser side effects. Now, with regards to the efficacy, or particularly clinical applications of antipsychotics, may it be first gen or second generation, again, they are very good in treating positive symptoms. So take note, they are both effective in treating positive symptoms in schizophrenia. Okay, so both first generation and second generation antipsychotics, they have that equal efficacy towards treating the positive symptoms in schizophrenia. Whereas in treating negative symptoms in schizophrenia, according to clinical studies, recent studies, second generation might help, okay, better in managing negative symptoms in schizophrenia. Okay, so second generation is much more effective, might help, no, somehow might help the negative symptoms observed among patients with schizophrenia. Okay, so again, both are equal in efficacy in treating positive symptoms. They only differ in treating negative symptoms. Okay. Now, talking about antipsychotics also, there are few antipsychotics that may also be used in other psychotic disorders. Say, for example, mania. Okay, there are antipsychotics used for mania, for Tourette's syndrome, for depression. Okay, but our focus here is the disorder schizophrenia in treating the positive symptoms of schizophrenia. And antipsychotics in general, they are very good in treating the positive symptoms among schizophrenic patients because again, the positive symptoms, okay, observed among schizophrenic patients, that is very disturbing, that is very alarming, and that has to be treated or given with a proper pharmacological intervention. Now let us proceed to the adverse effects of both first generation and second generation antipsychotics. Let us start with the extrapyramidal symptoms. Now, talking about extrapyramidal symptoms, we have five: acute dystonia, akathisia, Pseudo-Parkinsonism, the NMS or neuroleptic malignant syndrome, and the Tardive Dyskinesia. So, obviously, all this reaction or all these extrapyramidal symptoms are related to dopamine blockade. Okay, we try to review again the discussion earlier. The upon blockade, no, of dopamine receptor EPS, okay, is expected as an adverse effect or a side effect. Okay, now the first EPS, okay, that is seen upon intake of antipsychotics, okay, usually first generation antipsychotics, is the acute dystonia. Okay, acute dystonia, once again, this is the first EPS being seen. Okay, as mentioned in the table, diba? This is being developed an hours, few hours, or days, no, few hours or days upon taking the antipsychotic drug, acute dystonia may be developed. So, what are the features or manifestation of a patient having a dystonia? Acute, okay, acute dystonia. There is spasm of muscles of the tongue, face, neck, back. This manifestation features medical term that describes this is torticollis or retrocollis. Okay, so if there is spasm of muscles in the face or neck or back, that describes acute dystonia. And for this reaction, okay, this is easier to treat. Okay, this is easier to treat than any other EPS, okay, observed among schizophrenic patient taking antipsychotics. Okay, yes, it may be easier to treat, but it can be fatal. Okay, that is why there has to be a treatment. Okay, if this reaction is being observed upon taking antipsychotic, the drug of choice for dystonia is diphenhydramine, okay, via IV injection. Okay, another is promethazine, which is an anticholinergic agent. Okay, Next, we have akathisia. Akathisia, this is manifested with uncontrollable restlessness. Okay, there is uncontrollable restlessness, uncontrolled restlessness. Akathisia, unlike dystonia, this is the most difficult to treat. Okay, this is most difficult to treat EPS. In fact, this is the only EPS that is not treated with anticholinergic agent. Okay, not treated with anticholinergic agents. Okay, so for this reaction, it usually develops um, days to months. Okay, days to months upon taking anticholinergics. Okay, so how to manage this reaction? Okay, the best management is via taking benzodiazepines. Okay, benzodiazepine, this is an anti-seizure a drug. Another is a beta blocker, usually propranolol. Or you can reduce, okay, the dose or change the drug using these agents. Okay. Next, we have pseudo-Parkinsonism. Okay, so this was mentioned earlier. Pseudo-Parkinsonism is just a false Parkinson's disease. Okay, so what are the features? The same with the features having Parkinson's disease. The patient is observed to have tremors, rigidity, akinesia, postural instability, shuffling gait. Okay, so when this reaction it usually develops 5 to 30 days. Okay, 5 to 30 days. So, with regards to this reaction, again, this is somehow related to antagonism of dopamine, decreased level of dopamine in the Nigros Triatal, okay, system. That results to with the decrease of dopamine in that system, that results to uncontrollable spasms like tremors. Okay, there is involuntary movements, okay, of muscles. So with this reaction, Parkinson's-like symptoms is being observed, then the best treatment could be anti-Parkinson's disease, or we can use the following agents. These are anticholinergics. Okay, anticholinergics. Why anticholinergics are usually used as treatment for the symptoms associated when taking antipsychotics? It is because if you try to observe with pseudo-Parkinsonism features, this involves involuntary motor movements. Nagkakaroon ng um, um, biglaang spasm ng muscles, consistent na contraction ng muscles. And recall that anticholinergics, there are anticholinergics that are considered skeletal muscle relaxant. Diba? There are anticholinergics that are considered skeletal muscle relaxants. Okay, so that is the reason to relax the muscle. So example of anticholinergic is trihexyphenidyl, the procyclidine, benztropines. Next, neuroleptic malignant syndrome. This is usually characterized with having fever, okay, an increase no in body temperature, increase in body temp. Okay. Another is there is increased muscle contraction. Okay. With regards to the time of the maximal risk, this usually develops within weeks, or this usually persists for days after stopping neuroleptics. Okay. And the best way to manage this is use dantrolene, drug of choice. Dantrolene is a muscle relaxant. Okay. This is also an anticholinergic, diba? Muscle relaxant. Okay, dantrolene is a muscle relaxant. Another agent that can be used to help no this reaction to to manage is bromocriptine. Or if this agents, okay, for this agents, the patient is unresponsive, okay, walang effect, then simply stop the neuroleptic being taken by the patient. Next, tardive dyskinesia. Okay, tardive dyskinesia. With regards to the features, okay, this is usually observed having oral facial dyskinesia, okay, or and having dystonia. Okay, what is the reason? Okay, bakit nagkakaroon ng dyskinesia, dystonia? Okay, it is because of the hypersensitivity of dopamine receptors. Okay, so overactive yung dopamine receptors. Okay, hypersensitivity of dopamine receptors. Kahit wala namang nag-bind, okay, hindi naman enough yung nag-bind na dopamine neurotransmitters to the specified receptor, nagre-respond pa rin siya. Okay? And supposedly, we are blocking here the dopamine. Okay? So what happens is nagkakaroon ng excess, no? Baliktad, excess function of dopamine. So simply stop, no? Neuroleptics. That is the best way to manage tardive dyskinesia. Okay. Usually, this occurs upon abrupt kanang bigla ang withdrawal of the neuroleptics being taken by the patient. Okay. Now to manage again, you can discontinue the neuroleptics, or you can change the agent being taken by the patient. Usually, ang not alternative, yung binibigay, okay, to somehow manage tardive dyskinesia is clozapine. Okay, because among the antipsychotics, this is the only antipsychotic drug that do not cause EPS. Okay? So para maiwasan yung EPS, specifically tardive dyskinesia. Okay? So again, clozapine is the only antipsychotic drug that do not cause EPS. But it doesn't mean na siya na agad yung first na ibigay sa pasyente, knowing na hindi siya nagkukos ng EPS. It is because yung clozapine also has other adverse effects. Hindi nga siya nagkukos ng EPS, but it causes other adverse effects. Okay? So later, we will discuss, what are those clozapine's side effects that has to be considered. Okay? So those are again the extrapyramidal symptoms that is usually observed among patients taking neuroleptics. And again, these EPS are somehow related to dopamine blockade. No? Upon blocking of dopamine with that general mechanism of action ng mga antipsychotics, these are usually observed. And again, we have different ways to manage each reactions. Next, let us proceed to the other adverse effects, which is not related naman to blocking dopamine receptors. Example, endocrine effects may be observed as a side effect for those patients taking neuroleptics. Okay, a specific endocrine effect is galactorrhea. This is usually caused by hyperprolactinemia. Okay, hyperprolactinemia. Okay, recall that dopamine is considered a prolactin release inhibiting hormone. Okay, so without dopamine, without dopamine, presence of dopamine, there would be continuous release of prolactin. That will cause hyperprolactinemia. Okay? Para saan yung prolactin? For milk production. That is why it is usually manifested with galactorrhea. Okay? Galactorrhea, that is excessive discharge of milk from the breast. Okay, again, that results to this is related, no, to dopamine blockade. But the rest, okay, these are not related to dopamine blockade effects. Okay. Next, we have postural hypotension. This is primarily caused by blockade of alpha receptor. Okay, particularly alpha 1 receptor. If you try to scan over your notes, blockade of alpha 1 receptor, that results to vasodilation. Okay, that is why there is postural hypotension. For anticholinergic effects, this is the result upon blocking muscarinic receptor. Diba? Muscarinic receptor is a cholinergic receptor. So what would be the effect kapag na-block yung muscarinic receptor? Then, opposite of dumbbells. Okay? Opposite of dumbbells. Kaya may constipation, urinary retention, okay? Cycloplegia, dry mouth. Sedation, okay? This is developed, okay, or resulted upon blockade of histamine receptor, particularly histamine 1 receptor. Okay. So again, this three bullets related ito sa anti-ham activity, blocking activity, anti-ham activity ng antipsychotics. Okay? And these are the special naman na adverse effects that you have to note for selected na mga antipsychotics. So for example, with clozapine, take note, meron siyang anti-SAM. Okay, anti-SAM adverse effects. Okay, anti-SAM. So ito yung reason why it is not usually given as first antipsychotic treatment to patient kasi nagko-cause siya ng seizure, agranulocytosis, myocarditis. Okay? When I say agranulocytosis, A means absence. Okay? Absence of granulocytes. What are examples of granulocytes? Granulocytes, these are granules present sa white blood cells, particularly the basophils, eosinophils, the neutrophils. So, mababa kasi agranulocytosis. Mababa yung BEN, yung basophils, eosinophils, neutrophils, no? Kaya, if this occurs, or not really occurs, no? If you wanted as a prescribed, as an attending physician, okay, then you intend to prescribe clozapine, the first thing that you have to note is to you have to require WBC count, okay, white blood cell count, okay. Then if it is okay naman for the patient, then you give the clozapine. But upon giving clozapine, we have to monitor the patient's white blood cell count because later on along the treatment with clozapine, remember it causes agranulocytosis, it may decrease these granulocytes in the white blood cells. That's why take note to require WBC count monitoring every week, no? Or usually for the first 6 months of treatment. Okay, for the first 6 months of treatment, to a patient taking clozapine, you have to require WBC count. Hindi naman every day, hindi rin every week. You can have it every 3 weeks. Okay, every 3 weeks. With that, 6 months, every 3 weeks, you have to have a WBC count monitoring for that patient. Okay. Cardiac side effects, this is also very alarming. Okay. This is very harmful because puso na yung target. So, yes, although hindi siya nagkakos ng EPS, but look at its other adverse effects. Meron siyang, hindi siya anti-SAM, no? Meron siyang SAM effects. Okay? SAM effects. Seizure, agranulocytosis, myocarditis. Okay? Then, QT prolongation. So, somehow it causes irregular heartbeats. Okay? Next, with chlorpromazine, which is a least potent first-gen antipsychotics, it causes naman corneal lens deposits. Okay, with corneal lens deposits, this do not cause blindness. Okay, this adverse effect does not cause blindness, no, to patients. So, ang iyong mnemonics ani is cannot, I can see, no, see, see, see. Okay, can see. Ano lang, see. Can see pa. But with retinal deposit, this somehow causes blindness. Okay, this causes blindness. So, yung letter R, pwede yan yung gamitin nyo as mnemonics. Retinal deposits, thyroidazine. Okay, siya yung nagkakos ng blindness. CC, chlorpromazine, corneal lens deposits, can still see. Okay, then we have atypical antipsychotics that causes weight gain. This is because of their ability. This is because of their other miscellaneous nga activity towards histamine. Okay, because of blocking histamine, they somehow boost the appetite of the patient. That is why nagkakaroon ng weight gain. Okay, then with regards to olanzapine, it causes risk of diabetes mellitus because with olanzapine, it causes insulin resistance. Okay, it causes insulin resistance. Another thing also with regards to atypical antipsychotics that causes weight gain, hindi naman lahat. Okay, yung exception dito, lagay ko na lang yung except. Okay, yung last 3 listed na second generation antipsychotic, yung aripiprazole, molindone, tsaka yung amylsulpride. Those atypical antipsychotics, they do not cause weight gain.